Good evening, everyone. Blood shortages and inadequate screenings for infections through the lens of comparative health. Again, I'll just give a brief introduction about myself. My name is Rana, and I'm a rising senior at Oakton High School. I enjoy presenting for my school at HOSA conferences, and as a former Girls Who Code instructor and vice president of my school's Kids Can Be Scientists 2 chapter, I work to expose kids to areas of STEM they may not have learned about. I hope to continue pursuing my love for medicine and computer science as a bioinformatics major and ultimately as a medical student.
Hello, everyone. My name is Elena Dower, and I'm an incoming first year at Georgetown University, majoring in global health. I'm incredibly passionate about refugee emergency medicine, and I currently practice as an EMT and also lead my nonprofit, Ethica Global Alliance, which serves underserved students through education and healthcare. I plan on pursuing medicine and health policy for disadvantaged communities, and we plan to present to you all today about medical shortages with a focus on blood and inadequate screenings. And so just moving right along, as we can see on the screen, there's an urgent need for an effective procedure to address inadequate screenings, which has only been exacerbated in consideration of the vast commonality of blood transfusions in the COVID pandemic. Our topic addresses possible solutions to the issue while highlighting the inconsistency of blood transfusions in rural countries, ultimately in order to address the increasing demand for blood.
A little bit more background. Due to a lack of standardization and education rather than harnessing a tool of prevention and treatment, inadequate screening procedures actually result in an unreliable blood supply, which deepens the severity of health issues and diseases, including HIV and syphilis. And this is really perpetuating itself through rural, underdeveloped, and refugee areas. As two case studies, we're going to be focusing on Ethiopia and Syria. So we used 4 measures of efficacy to consider the transfusion systems of each of our case studies, the first being the ability to acknowledge history and environmental factors, which in Ethiopia is at little to none, the sensitivity of screening to major blood markers, which is at 62.5%, transfusion transmissible infection rate, which is at 12.5%, and level of inadequate blood screening, which in Eastern Ethiopia is at 11.37%, while in Northwestern Ethiopia is at a shocking 43.2%. So researchers are really noticing 3 significant problems with the Ethiopian transfusion system, the first being a lack of standardization. As shown in the previous slide, the prevalence of inadequate transfusions in the North and the West is significantly higher than that of the East, and this is because a national transfusion system has not been implemented, meaning that each region is using different equipment, different labeling systems, and so on, which causes a deep disparity in the quality of care that sections are receiving. Additionally, not only is blood being inappropriately screened, but it's also being overused, dwindling the safe blood supply. Over a 2-year period, researchers found that about 58% of the transfusions that occurred were not necessary. And this is again stemming from a lack of standardization and a lack of national criteria that doctors can go off of. The second major problem is the on-demand collection system of blood that's being used. The World Health Organization recommends that the majority of blood collection be from voluntary donors. However, Ethiopian statistics are actually reflecting the opposite, with a vast majority of blood being collected from replacement donors. And this collection system is really problematic because during periods of unrest, more replacement donors are motivated to donate blood, whereas in times of peace, the Ethiopian system will need to rely on the voluntary donors, which make up a really narrow portion of donations, which will cause the system to be overwhelmed by demand without adequate supply to meet it. The third major problem is the lack of acknowledgement of the environment that the Ethiopian system is exhibiting. Despite malaria being deemed endemic in Ethiopia and having the ability to be identified through blood markers, most blood banks are not screening for malaria and are using similar screenings as to that of European countries, including Greece and the Ukraine. Transfusion is not a one-size-fits-all system, and because the environment of diseases in Ethiopia differs from that of Europe, collection protocol has to vary accordingly. So just a quick recap, the 3 major issues with the Ethiopian system is a lack of standardization, acknowledgement of the environment, and adequate voluntary donors, which causes the system to exhibit extreme TTI infection rates and inadequate screening percentages. Passing it on to my partner, Aleena, who is going to be considering Syria through a comparative health lens.
Yeah, so for the case study on Syria, as many war-torn countries are, there's a lack of national data on the situation. And so what we do have is that we do know that there's no acknowledgement of environmental factors such as war, housing, and hygiene. And the transfusion transmissible infection rate is 17%, making it a recent study done by the Journal of Hematology and Infectious Diseases that 1/6 of Syrian patients most likely acquired an HPV/HCV infection via a blood transfusion. So the lack of national data on the situation in both developed and developing countries reflects that this is an area of blood transfusion safety where more intention and more interventions are required. In addition, operational studies and clinical use of blood are required so that more information and evidence are available. And on the next slide is more of a representative of what Syria is looking like right now and many other war-torn countries. So as you can see in the top right, you see an EMT ambulance like completely crushed. Bottom left, you see a hospital totally vacant and closed off. So Syria is a prime example of just how a country under war can lead to detrimental impacts to a country's health, such as blood donations and proper screening. And ever since the civil war started in 2011, economic sanctions, currency fluctuations, increase in operational costs have all negatively hurt the production of medical services as the ones that you see on the slide. And so on these images, you can see that the health sector has been heavily affected in conflict areas as hospitals and health centers that conducted surgical and trauma care have been closed, damaged, or controlled by parties of the conflict. Public health facilities are also inaccessible due to the ongoing violence and the lack of public transportation. And the World Health Organization has identified urgently needed medicine, including those for tuberculosis, hepatitis, and other chronic health conditions, one of them being thalassemia, which is the main focus of our presentation. So onto the next slide, we will see, so in besieged areas in Syria, many are suffering from this inherited blood disorder. It's a disease caused by an alteration in the genes of the protein subunits of the hemoglobin molecule. And we can see in that diagram, the more alterations in those alpha and beta chains, the more severe the disease. So in Syria, we mainly see severe cases in which the best way to treat it is regular blood transfusions to compensate for the lack of hemoglobin. But the absence of supplies and adequately screened blood banks have made it life-threatening. So, you know, thalassemia is no longer just a simple health issue, but it's now become extremely fatal. And at most medical centers where it's mainly run by rebel-run field hospitals, they're starved of medical equipment since the siege in 2011, and we see that in many other countries. And so onto the next slide, you've seen these images on the left, people dealing with chemical weapons. So another rising problem in war-torn countries, such as Syria, is the lasting effects of chemical weapons that have been found in blood samples testing positive for the nerve agent sarin. And this is really just the chemical weapon component found in Syrian civilians points to not just a health problem, but in actuality points to a much larger socio-political development underlying blood transfusion errors, which requires extra effort to ensure proper exchange. And on the right, we see that you might be wondering, like, where's the aid coming to Syria, right? Well, unfortunately, many, like, for example, the World Health Organization, their aid has been cut off by government-controlled areas of Syria. And so many patients and medical professionals no longer have that access to provide care for disorders like thalassemia. And again, like there's a lack of national data just to how many people are suffering, but because we have data in 2011 when the siege started, around 8,000 patients were already suffering from it, making it one of the top 10 recurrent illnesses in the country. And although the healthcare solution within Syria is lacking because of the political obstacles, we can still see solutions that can be implemented specifically for Syrian refugees in other countries. One that has been fairly effective has been in Turkey, where Syrian refugees are trained in Turkish hospitals and universities to become equipped as medical professionals to help their own communities. So that way they have that cultural sensitivity and intervention without straining the native Turkish population's healthcare system. And this could be implemented in other countries that are suffering from the detrimental impacts of a large influx of refugees or the lack of the ability to take care of these refugees in their healthcare system. And now as we come to an end, I'll hand it off to Rana regarding a few more proposed solutions.
Yeah, so for our last proposed solution, standardizing blood collection and transfusion on national levels is the first step to increasing the safety of blood procedures, and establishing specific expectations as to what screenings are used helps minimize the disparity between quality of care that's delivered to countries that are primarily of the middle to higher socioeconomic statuses and countries that are developing, thus furthering the accessibility of both routine and emergency healthcare.
Lastly, we would just like to acknowledge and thank all the authors and researchers who have brought in our perspectives on this topic. We'd also like to thank the Global Health Leaders Conference Board for giving us the opportunity to share the topic. We also appreciate all those watching today. It's been a really fun presentation to put together, and we hope you got something out of it.
course, feel free to contact us with any questions you might have. Thank you.